Welcome to our discussion on infections of the respiratory tract. With a focus on lower respiratory tract infections, this session emphasizes on pneumonia, while also acknowledging pulmonary tuberculosis and important fungal infections such as Pneumocystis jirovecii. That also falls within the lower respiratory tract infections umbrella. These infections are amongst the major causes of morbidity and death in Kenya, particularly among individuals at the extremes of age, the very young and the elderly, as well as those with pre-existing lung conditions or weakened immune systems. Many of the chronic lung diseases we've discussed previously can predispose patients to these infections. Why is pneumonia important? The importance of any disease is considered based its major implication on the population. Between 2017 and 2021, 8.7 million cases were reported in health facilities, peaking at 2.15 million cases in 2021 alone. Pneumonia claims 8,000 to 10,000 young lives annually, representing roughly 1 in 5 child deaths. In 2018, an estimated 9,000 children under 5 died from pneumonia in Kenya. That is 24 child deaths per day, once accounting for 15% of all under 5 mortality. It remains the leading infectious killer in children. These are data according to Ministry of Health Kenya 2022, Kenya National Pneumonia Control Strategy 2023 to 2028. Let's begin with pneumonia. Anytime we hear the term pneumonia, we think of inflammation of the lung parenchyma, that is, the alveoli, bronchioles, and surrounding capillary network. These are important areas for gaseous exchange. In most cases, pneumonia results from an infectious process, whether bacterial, viral, or fungal. Under normal conditions, the immune system protects the lungs. However, aggressive infections or compromised immunity, as seen in patients with cancer, uncontrolled diabetes, HIV or AIDS, or those on chemotherapy or high-dose steroids, can allow infection to take hold. These are referred to as opportunistic infections, as they exploit weakened immunity. Clinically, pneumonia typically presents with cough, often productive of purulent sputum, breathlessness, fever, chest pain, especially pleuritic in nature, crackles or wheezing on auscultation. In radiology, pneumonia manifests as lung consolidation, which may be localized or widespread. We have 2 major criteria for classifying pneumonia: anatomical and clinical classification. Anatomical classifications of pneumonia. We have lobar pneumonia, which affects an entire lobe of the lung, represented by a well-demarcated area of consolidation on a chest X-ray. Patients tend to have, usually more severe in symptoms, segmental pneumonia, which involves a segment within a lobe. You need to be keen, because it can resemble a mass on imaging, requiring differentiation from malignancy. Another anatomical form is interstitial pneumonia. It involves the lung interstitium, causes diffuse infiltrates or a ground glass appearance on imaging, associated with chronic inflammation or fibrosis, which can give you restrictive features when doing lung function test, where lungs lose their elasticity and fail to expand maximally. The last form is bronchopneumonia. The inflammatory or the infection starts in the bronchi and spreads to the alveoli. Patchy consolidation across multiple lobes can be seen, commonly linked to wheezing and mucus production. Clinical classifications by setting are community-acquired pneumonia CAP, normally acquired outside hospital. Streptococcus pneumoniae is the most common cause. Risk factors include age, chronic disease, smoking, alcohol use, and immune suppression. Hospital-acquired pneumonia HAP. This usually occurs after 48 hours of hospital admission. It frequently involves drug-resistant organisms. Ventilator-associated pneumonia VAP, likely to develop in mechanically ventilated patients, requires prompt treatment based on EQ-specific pathogens. Aspiration pneumonia, caused by inhaling oropharyngeal or gastric contents. Risk factors include impaired swallowing, altered consciousness, or reflux. As a clinician, you need to identify this because successful treatment is dependent on addressing the key causes. Opportunistic pneumonia, seen in immunocompromised hosts. Causes include fungi like Pneumocystis jirovecii, cytomegalovirus, herpes simplex virus, and others. Now, let's talk a little bit about the clinical features. As a clinical officer, your eyes, hand, ears, nose, mouth, and intuition becomes the most useful tool that helps you discern signs and symptoms through clinical history and physical examination. The picture that you are likely to see in your outpatient could represent, in your history, an elderly or young child, maybe with occupation that might expose them to dust, chemicals, or infectious environments, living in an overcrowded areas, poor ventilation, cold climate. Noting all of these while charting their biodata history, some of the chief complaints that they are likely to have includes cough, difficulty in breathing, dyspnea, chest pain, fever, fatigue. If you are keen enough, the onset, duration, and progression of your patient's complaints is likely to have some of these patterns, like cough may be dry or productive, often purulent or rust-colored sputum, fever, continuous or swinging, breathlessness, mild to severe, may worsen on exertion, chest pain, that is typically pleuritic sharp, worse on deep breathing, hemoptysis in some cases, associateginal symptoms of fatigue, malaise, chills, night sweats, extrapulmonary features such as headache, confusion especially in elderly, myalgia, joint pains, gastrointestinal symptoms like nausea, diarrhea, etc. Past medical history, chronic respiratory diseases, COPD, asthma, bronchiectasis, previous pneumonias, or frequent lower respiratory infections, HIV/AIDS, diabetes, renal failure, malignancy, history of tuberculosis, vaccination history, history of recent hospitalization or surgery, risk for nosocomial pneumonia. Start your respiratory exam with a general inspection. Look for fever, fast breathing, or signs like cyanosis and pallor. Confusion or dry skin may hint at dehydration or uremia. Notice if the patient uses accessory muscles or has clubbing of the fingers. Cold sores or rashes might point to specific infections. Now move to the chest. Check chest movement. Reduced expansion suggests a problem on that side. Watch for nasal flaring or retractions, especially in children or severe distress. During palpation, feel for reduced expansion and vocal fremitus. Tenderness may indicate rib pain or pleuritis. Percussion helps identify fluid or air. Dullness suggests effusion. Hyperresonance suggests pneumothorax. When auscultating, listen for bronchial breath sounds, crackles, or rubs. Signs like egophony or whispering pectoriloquy point to lung consolidation. Always stay alert. Diseases don't always follow the textbook. It is also worth to inquire about family history of a patient. These helps you as the clinician or a doctor to understand the spread and the role of genetics in the pathophysiology. The likely positive findings in familial history are tuberculosis, chronic lung conditions, immunodeficiency disorders, recurrent respiratory infections in siblings or household members. Unaided lung. Other systemic examination findings are cardiovascular, murmurs of infective endocarditis, suspected abdomen, tender hepatomegaly, right lower lobe pneumonia, splenomegaly and atypical or disseminated infections, neurological. Confusion, reduced level of consciousness, delirium, sepsis, uremia, skin, cyanosis, rash, signs of dehydration, joints, arthralgia for example, mycoplasma, pneumonia, eyes, conjunctival, pallor, anemia, signs of dehydration. There are several organisms that can be linked to pneumonia. Example include mycoplasma pneumonia that majorly affects young adults, can present with systemic symptoms. Haemophilus influenzae, which is common in elderly and chronic obstructive pulmonary disease patients. Legionella pneumophila found in contaminated water systems. Klebsiella pneumonia, associated with alcohol use and lung cavitations. Staphylococcus aureus, may follow viral illnesses like influenza. In many cases, no single organism is isolated. This makes empirical treatment and clinical judgment essential. You need to remember, a good clinician will carry out laboratory and imaging investigations too. Diagnose the condition, determine the extent, trace the possible causes, and tell the likely complications. What are some of the investigations that you will order as a clinician? Chest X-ray, which is likely to confirm presence and extent of consolidation. Note that, where patients have mild disease, chest X-ray is not routinely recommended unless they fail to improve after 48 to 72 hours. Blood tests. Full blood count, which may show neutrophilia, suggesting an infection. Elevated blood, urea, and electrolytes level that may suggest dehydration, stress response, and muscle breakdown. CRP. C-reactive protein CRP is a blood test used to detect inflammation in the body. In the context of pneumonia, CRP plays an important role in diagnosis, monitoring, and management. You can also request microbiological tests such as sputum and blood cultures to isolate specific organisms and to know the sensitive antibiotics. Urine antigen tests, for example, for Legionella, Streptococcus, pneumonia. Note that diagnostic microbiome tests are not needed in mild infection, which should be treated at home with standard oral antibiotics, amoxicillin or clarithromycin. For those with a history of penicillin allergy, arterial blood gas, that will help you assess oxygenation and blood pH in severe disease. An HIV test should be offered to all patients with pneumonia, since it is a common initial presenting illness in previously undiagnosed HIV infection. With the above laboratory test and clinical assessment of the patient, you need to decide whether you're them handling as outpatient or inpatient. That means you need to assess the severity by use curve -65 or CRB-65, where C stands for confusion, U for urea greater than 7 mol LR, for respiratory rate is greater than or equal to 30 per minute, B for blood pressure 90 mmHg systolic or 60 mmHg diastolic, 65 for age is greater than or equal to 65 years, where you assign 1 point for each of the above. You will notice that the two scoring systems are same, only that the CRB-65 score is used in a community where the serum urea level is not usually available. How do you interpret your score? A score of 0 to 1, manage as outpatient. A score of 2, consider inpatient care. A score of more than or equal to 3, likely requires ICU admission. Low blood pressure alone, even with a low score, is a warning sign for close observation. These scoring systems can also be used in your course of treatment to assess how the patient is responding to treatment. When it comes to management, supplemental oxygen should be administered to maintain saturations between 94% and 98%, provided the patient is not at risk of carbon dioxide retention due to loss of hypoxic drive, and intravenous fluids are required in hypotensive patients showing any evidence of volume depletion and hypotension. The first dose of antibiotics should be administered within 1 hour of identifying any high-risk criteria, and treatment should not be delayed while investigations are awaited. Parenteral antibiotics should be switched to oral once the temperature has settled for a period of 24 hours. Provided there is no contraindication to oral therapy. If the patient is admitted for more than 12 hours, subcutaneous low molecular weight heparin should be prescribed and thromboembolus deterrent. TED stockings should be fitted, unless contraindications exist. Chest physiotherapy is not needed, unless sputum retention is an issue. Nutritional need is assessed by a dietitian, particularly in severe disease. Simple analgesia, such as paracetamol or an NSAID, helps treat pleuritic pain, thereby reducing the risk of further complications due to restricted breathing because of pain, for example sputum retention, atelectasis, or secondary infection. What does the Ministry of Health in Kenya recommends in terms of antibiotic? 1 for CAP admitted or with comorbid excessive amoxicillin clavulanic acid, 875 milligrams, 125 milligrams, orally 12 hourly, or 1.2 grams for every 8 hours, for 5 days. For severe CAP, add one of the following: azithromycin 500 milligrams orally once daily, for 3 days, or clarithromycin 500 milligrams, orally twice daily for 5 days. 2. For hospital-acquired pneumonia, HOP, or ICU-level illness, give piperacillin tazobactam 4.5 g for every 6 hours for 7 days. Amikacin 15 milligrams per kilogram, day 4 for 7 days. If there's concern for Mr. SA, add linezolid 600 milligrams for twice daily or vancomycin, pending culture results. If the disease is not adequately addressed, some of these complications may occur. Empyema, which is pus in the pleural cavity. Pleural effusion, referring to fluid accumulation in the pleural space. Respiratory failure, sepsis, and organ dysfunction. Delirium and metabolic encephalopathy from elevated urea. Anemia, especially in prolonged illness or uremia. For follow-up, do a chest X-ray at 6 weeks to rule out malignancy or chronic disease. Monitor kidney function and hemoglobin in complicated cases. In conclusion, pneumonia is a multifaceted illness that requires comprehensive assessment, accurate classification, and timely treatment. Recognizing risk factors and red flags like confusion, high urea, or respiratory distress can save lives. That brings us to the end of our discussion on pneumonia. Thank you for your attention and dedication to learning. Wishing you a productive and insightful day ahead. Stay tuned for our next lecture, where we'll be covering tuberculosis and fungal infections of the respiratory tract. Until then, keep learning and stay well.